Okay, thank you. Thank you so much. It is a great pleasure for me to be here. I would like to thank you for inviting me to be here. And at the same time, I'm going to talk about one of my favorite topics in medicine and in electrophysiology. So I'll talk about leadless pacing. It is almost impossible not to think in future when you're talking about leadless pacing. The best way to predict the future is to create it. My disclosures. In the very beginning, we were talking and celebrating about big technologies, and actually they were very big. They were the first pacemakers in the world, and that was like 70 years ago. So with time, we started celebrating something more tiny, smaller devices, and we started 70 years after, we started celebrating that there was small technologies that performed the same procedure, but with very tiny device. So we started in 2013 with these small micro devices, micro pacemakers. And then in very fast, 7 years after, we started developing like more synchronic pacing. In 2020, we started with AB synchrony. After that, we were searching for more advanced technologies, and nowadays we are dreaming with more physiologic technologies in the same area. So today's agenda is to review a little bit about the whole procedure, and then we will go to specific topics. So let's start. This is more or less the procedure. We start with a puncture. It's very similar to what doctor just talked about. We approach via femoral, but this is vein, not an artery. So we go up, and then we start like just going into the right ventricle, and we confirm that we are in the right place before deployment of this micro pacemaker. Then we leave the pacemaker in place, and then we start performing electronics in order to know if it's stable inside the ventricle and in order to know that it's pacing in the proper way. And then after we cut all the control that we have between the device and the delivery system, and then we leave the pacemaker inside already with the capacity of pacing the patient. So this is the micro, how it started. In the very beginning, we had two types of pacemakers. We had one from Medtronic, one from Abbott, and they both perform almost the same thing, but with different delivery systems and with different attachment system. So we had problems with Abbott device that was called Nanostim, and the other one that was in the market since then was Micra from Medtronic. And since then, we have like the very initial study, and we have several studies that have demonstrated efficacy in terms of pacing. So we have capacity to stimulate, to pace the ventricle in a proper way with good sensitivity and good threshold during the time, so we can pace in a proper way. Why not a conventional system? Why not keep doing the way that we were doing for years? Because many times more exposure can lead to many complications. So as we can see here, we have a pocket problems, like for instance, I can have pocket infection, erosion, hematoma, and also related to leads, we can have fractures of the leads, we can have perforation, effusion, tamponade, so everything can lead to a problem once you're using leads. And actually, the databases show us that sometimes we can have big complications and also very frequent complications. So this is what we are trying to avoid. Most of the complications are related to leads, but we also have complications related to pocket and pocket hematoma, erosions, and infections. We have seen that with leadless pacemaker, we can reduce the complications in a big amount, like 63% of the cases can be avoided. And this is a special complication that we need to avoid, that fortunately, it's not so common, but it can be very deadly. It's infection. For instance, here we have, from the very beginning, we started seeing that the complication of infection in this kind of devices was very small in the databases and the series of patients. So many patients need to remove the device because of infection, endocarditis, and even thought they had bacteremia, endocarditis, and also sepsis. They implanted the devices immediately, and we saw that it was not common to have an infection. So when you start thinking on that, then you realize that maybe the 10 times higher cost of a device like a Micra, it's justified because once you have complication of leads, complication of pockets, erosion, endocarditis, then you can compensate actually the whole price of a leadless pacemaker. And that's actually the conclusion that the people from Norway had once they started analyzing the benefit of implanting leadless pacemaker. So why this lower infections rate? We actually don't know, but we have a lot of hypotheses. For instance, the fact that we don't have a pocket, the fact that we don't touch the device, the fact that we don't have leads or something like a bigger area to infection, the early encapsulation, or maybe something related to a turbulent environment where we leave the device. So this is the early encapsulation we have seen in many patients post-mortem. They go to an anatomy analysis post-mortem, and they find that many devices are encapsulated only a few months after the implantations. So current indication, that's easier right now because we have guidelines that talks about a specific leadless indication. So if we have a difficulty of access, venous access, of a higher risk of device pocket infection or previous infections or hemodialysis, then we have a class 2A with level B of evidence to indicate this kind of devices. But if we have something related to life expectancy, we can consider and we can discuss, so we can individualize as a class 2 indication according to the ESC 2021 guidelines. So where are we now? What do we have to do now? So the options that we have in the market, it's Micra BR, AB, Micra 2, AB2, and also this relatively new device that Abbott developed, that it's like the second generation after NanoStim, and it's the only dual chamber pacemaker. So when we talk about pacing, we want something extremely close to what is normal in the heart, normal in physiology. So they started thinking of that, and they started developing a device that can sense the atrium and pace the ventricle. And the trial Marvel 2 demonstrated that with Micra, we can sense, we can feel the atrium, not in an electrical way, but in a mechanical way. I can feel the atrium and started following the atrium, pacing just the ventricle. And with a high efficacy, they demonstrated that even though they changed it with postural maneuvers, they still had this AV synchrony. But that was not enough. They started implanting devices in the atrium in ships in animal models. So now we have this trial that it's demonstrating that it is possible to implant a Micra in the atrium, and it's also possible to retrieve the Micra and implant another one in the same place. But Abbott went beyond that and started experimenting in a dual chamber pacemaker, leadless pacemaker. So they published this in 2023, and they have also the approval in CM market and also in FDA. So they started with this device that is the AVEIR dual chamber pacemaker. So the AV synchrony is possible in a high amount of patients. And actually, real pacing of the atrium is possible, as you can see here with one of the patients of the EKG of the patients. So AVEIR, we go to monitor, then we go to implant of the ventricle, then we go to the delivery of the atrium. The mechanism is different from Micra. You just go inside, like going inside, turning around, and then you can synchronize both in order to pace without any lead. But is that enough? We were thinking that not. AV synchrony is not enough in most of the cases, because nowadays we're thinking more on physiologic pacing. But what about second generation of Micra? This improved a lot the longevity of the devices, improved a lot the AV conduction algorithm, and also the delivery system was improved in this kind of patients. And as you can see, the battery longevity went to 16 to 70 years in media, so it's quite nice. And it's better because most of the cases, the only leadless pacemaker that you implant will be the only pacemaker in the life of the patient. So it's enough. But sometimes it's not enough to think on AV synchrony and dual chamber. We're thinking on pacing the conduction system. And this is one concept that started in Latin America. Because in Latin America, we have some sort of EKG, objective EKG, to demonstrate synchrony, that it's called Synchromax, developed in Argentina. And we have a lot of evidence related to that you can demonstrate with an index how synchronic the pacing is. So we published in 2021 the first case of leadless pacemaker guided by Synchromax. So the idea was to implant the pacemaker and demonstrate how well the index was. So as you can see, this is some sort of objective index, as you do when you're trying to demonstrate mechanical synchrony once you go to a speckle tracking or strain in echocardiogram. So you can do almost the same electrical synchrony, an index, objective index, as here. If you have an index very high, above 0.2, then it's not synchronic. And if you have index that improves and goes like this, you can say that it's synchronic, for instance, in this place. So it is all well demonstrated with conventional pacemaker, but we are trying to dream to have this synchronic indexes in leadless pacemaker. So we all know that septal implantation is a routine in Micra and leadless for safety, but if we can map the septum and know where in the septum we can put a more physiologic pacing, then in the future maybe we will be talking more about septal implantation as a routine, but more for synchrony rather than safety. This is our research, and these are the first results of our research. We will go to the septum, we map the septum, and we try to explain where it's better to implant the Micra. So these are our results. We have indexes, high indexes in the beginning, and in some areas of the septum, we improve the indexes. So that's interesting because we could be synchronizing with a leadless pacemaker. Some areas are not good to pace, as you can see here, and some areas are like neutral, and some other areas of the septum could be synchronic in order to improve and variate in an improvement the index of pacing. Leadless is running. It's running faster than any other therapy. I was hearing about TAVI and how much it has increased in the last 40 years, where we can see here in Micra and leadless that in 10 years we have improved a lot. 10 years ago we were celebrating the first implantation of Micra, now it's worldwide, and it is predicted that in the near future we will have like a giant market of leadless, and not only in terms of numbers, but also in terms of the amount of money that this leads to payment of the insurances and stuff. So to take home messages, I need to say that leadless is present on daily practice. Not only that, the indication might become mandatory in specific cases for some patients. And in the future, not very far future, we will be talking about leadless, physiologic leadless. And if that happens, maybe in the future, this will be the only idea of patient. So thank you very much. Stay calm and keep dreaming with leadless physiologic pacing.